AL amyloidosis can be a potentially life-threatening condition. The goal of treatment is to achieve early and rapid, deep hematologic responses, ideally at least a very good partial response by the consensus hematologic criteria. The regimen that we currently use in the frontline treatment was brought to the fore by the registrational Andromeda clinical trial, which demonstrated a very good partial response rate upward of 3/4 of patients, which was really transformational compared to what we historically had available. There's a big lacuna in terms of what we can use after Dara-VCd if these patients have a suboptimal response. And traditionally, we consider suboptimal response as someone who has not achieved at least a very good partial response with induction treatment. The treatment landscape there is pretty heterogeneous. One of the options that exists is either switching out the CyBorD component, the cyclophosphamide, Bortezomib, and Dexamethasone component with potentially an IMiD agent like either lenalidomide or pomalidomide. We tend to go more with pomalidomide because of toxicity reasons. And a lot of times we end up switching to a second generation proteasome inhibitor as well, or rather third generation proteasome inhibitor, carfilzomib being a common choice as well. A lot of times cardiac toxicity can be a limiting factor there, but really it's a potpourri of regimens that we tend to end up using after Dara-VCd. The goal of this study was to try and see how many patients, first of all, did not achieve an optimal response and what were the treatment patterns. We noticed that about 1/3 of our cohort of patients that had a suboptimal response ended up switching to a Daratumumab based regimen, either in the combination of an IMiD or a PI. The other group of patients that we saw were the ones that underwent an autologous stem cell transplant, again about 1/3 to 1/4 of patients. And then another 1/3 of patients ended up using venetoclax-based regimens, and that could be either as a single agent venetoclax or in combination with an IMiD or a PI. So it was really a smattering of different regimens. But despite this, what was very clearly noticeable from our data was when we tried using Daratumumab-based regimens, the rates of deep responses were inferior. The hematologic event-free survival rate was inferior compared to use of non-Daratumumab regimens. So essentially, switching to a non-Dara-based regimen would be something that would be highly encouraged in these situations. And if somebody's harboring an 11-14 translocation, I think venetoclax presents as a nice option. There is exciting data coming out for teclistamab and other bispecific antibodies in this space as well, which I think with time will gain more traction as well.